Hi, my name is Melissa Davis, and I'm an RN nurse manager at University of Arizona Medical Center on a medical surgical unit. I'm here to talk to you today about my evidence-based project of reducing hospital readmissions through post-discharge follow-up. So I'm addressing this issue because it's considered an opportunity to enhance the quality of care, and it's become a quality improvement and policy focus for many hospitals. Readmissions are a significant cost to hospitals and the patient. It's estimated that readmissions account for 30% of inpatient costs just on commercially insured, and also poor hospital transitions accounted for $25 to $45 billion in wasted spending due to complications and readmissions in 2011. CMS has also begun to place penalties for 30-day readmissions for certain conditions, and they offer incentives for programs to enhance career transition, so there's definitely a financial incentive. One study recently identified the challenge to decreasing readmissions. That out of 43 cited studies, only 16 provided an intervention that was deemed effective. So that brings us to my PICO question. Do hospital-admitted patients who receive a follow-up phone call from a nurse post-discharge have lower all-cause 30-day readmission rates than those who do not receive a phone call? So my search for evidence began with PubMed, and there's other, if I was going to do a more extensive search, there's other systems I could have used, but I just went with PubMed, and I kept the search term simple, post-discharge phone calls, which yielded me 31 results. I did a filter of 5 years English and clinical trials. Clinical trials because those are the highest level of evidence, and I wanted to make sure I had a high level of evidence. That brought me down to 5 results, from which I was able to pick my study. And I selected this study because it's a prospective, stratified, randomized study. And like I said before, it's considered the highest strength of evidence. So the study I selected is Prioritized Post-Discharge Telephonic Outreach Reduces Hospital Readmissions for Selected High-Risk Patients from the American Journal of Managed Care. And this study looks specifically at utilizing a post-discharge phone call for patient follow-up in order to reduce 30 all-cause readmissions. There's been many studies that have looked at mixed interventions. This is only the second study designed to look at reducing readmissions through discharge phone calls alone. The other study found a 10% reduction in hospital readmissions. So the research focus, the purpose was to determine if utilizing a case management-driven protocol for post-discharge phone calls that prioritized high-risk patients reduced all-cause hospital readmissions. Like I said before, the design was prospective, randomized, and controlled. Utilizing an outreach assessment tool that was delivered by the case managers, and the participants were assigned randomly to either prioritized or unprioritized groups or the intervention or control group, respectively. The groups were stratified, so that way it created comparable groups at baseline, and the study also was blinded in that it created a blinding method of assigning the calls to the 86 different case managers. Assessing the effectiveness of utilizing discharge phone calls and prioritizing based on risk can potentially help enhance the care transitions for patients, reduce hospital readmissions, and lower costs and increase quality of care and patient outcomes. The research methodology, the sample size was 3,998. And a group proportion power calculation was performed to determine the needed sample size. And this was larger than the determined sample size. The group was divided exactly equally among the control and intervention groups. Characteristics, 52% male. The mean age of the prioritized group was 50 and unprioritized was 49. All were enrolled in the same commercial insurance, but not necessarily the same plan within that insurance. The setting wasn't specified as it was discharged patients, and it didn't look at where they were discharged to or the status of their home environment. However, patients were discharged from hospitals in all 50 states, excluding California and Texas that had other ongoing similar projects at the time. And all the hospitals were represented proportionally. Patients were matched according to age, gender, risk score, diagnostic group, count of prior 12-month admissions, insurance plan, and hospital facility. And they were matched. They basically had a twin in either the control group or the intervention group. Exclusions were inactive insurance coverage or no comparable match. Data was collected by case managers making the phone calls. Both groups received the same questions from the outreach assessment tool. However, the intervention group received the calls prioritized at 1 day post-discharge and the control group starting at 3 days. The questions focused on medications, management orders, and follow-up appointments. The measurements that are important to our PICO were time to contact and readmission rates, the percent of 30-day readmission rates, and then readmission rates per 1,000. The data was analysis was conducted by utilizing chi-square for discrete variables, one way for normal distributions, and Wilcoxon and Mann-Whitney tests for skewed variables, and the alpha was set to 0.05 for all. Our results, 44% of intervention and 35% of the control group completed the survey. The intervention group had a phone call 5 days earlier than the control. P was less than 0.05. The intervention group mean was 10 days and the control group was 15 days. The difference in results for 30-day readmissions was found to be statistically significant and was 5.7% for an intervention group versus 7.3% for the control group. Again, the P was less than 0.05. The readmission rate per 1,000 was 6% lower for prioritized group for 30-day, which was not statistically significant. However, it was at 60 days, which was 12% lower for the prioritized group. So there were several strengths and limitations here of our study. So the biggest strength, I think, is the stratification of the groups to decrease the differences between the intervention and control groups based on the demographics. The bias was utterly eliminated because there was a twin in each group. Study authors noted that all statistical analysis found no statistically significant differences between the two groups. However, I would say attrition was a concern to the internal validity. Less than half the patients contacted in either group actually engaged in a discharge phone call. And there were several limitations. The patient population was limited by diagnosis. They only looked at patients with circulatory, cardiac disorders, lower respiratory, or gastrointestinal disorders. There's also no way to identify patients' current or prior engagement in case management activity. And the patients in the study were all insured, which, as you probably know, is not always the case within an organization. So further study would definitely be needed to expand to high-risk populations. So implementation, it'll begin by looking at the current tool that's already used at the organization to assess readmission risks. It's a point-based up to 12 that's done on admission and as needed if situations change. Any score higher than 5 is considered high risk, and their patients get a flag on their banner within the medical record. There's also already a discharge call program called Patient Outreach, which is through, both of these are through Epic, our electronic health record. And so ideally, Epic will allow for a flow of the patients flagged as high risk for readmission per the current tool into a priority list within the discharge phone call system. If that isn't allowed by the system, then we can pull lists of patients who are considered high risk. The case managers already do that on a daily basis. So it'll involve the RN staff on the units, case management, quality control nurses, informatics, and Epic design staff will all need to be involved in this project. And basically, it'll start with a redesign and training on the use of a discharge phone call system. And we'll hopefully begin and review the design starting January 1st. Education in the program start to be determined after that. I'm not sure how long that'll take. I'm not a computer person. I'd like to start it as a pilot on one medical surgical unit within University of Arizona Medical Center. And we'll start this with a task force that, like I said, will include a QI department, case management, Epic representatives, and a unit manager. And education of the initiative and use of the program to the nursing staff. Costs, I think, will be minimal. The current workflow already calls for all bedside nurses to place discharge phone calls. However, there's no standard prioritization. It's pretty much just access the list and make the call. So the change will be in prioritizing high-risk patients and redesign of call questions to align more with the outreach tool already used in the study. The study utilized case managers to make the calls, but currently we don't have the staff at our organization to keep it focused on case managers alone. The cost really will just be the design of the program and education. So there won't be a cost really to begin making the calls. Many support resources in the institution. Discharge planning is already a heavy focus by leadership. Recently created a VP of Care Transitions position. The QI department encourages and guides in implementing EVP projects, and several committees are in place to utilize for support. The Quality and Safety Board, which meets on a monthly basis. Research and Innovation Council, which is designed as a focus for bedside nurses to begin projects. And the Clinical Systems Committee, which is basically the EPIC committee, and that would be who we would go to discuss any changes within the EPIC system. So dissemination of the project is really focused on communication and education. We'll start unit-based. Unit leadership includes management, but also the Unit Shared Leadership Council, which is made up of nurses and techs on the unit. They really take ownership of projects and improving care of patients on the unit, and they are empowered to make a lot of decisions. Email, posters. We'll also design some HealthStream modules for education, and then skills labs and role-playing. We really want to make sure we're educating the why behind the change. We don't want staff to see this just as another task. It's important to the safety and care of our patients that this is done, that we're following up with them. And like I said, we'll model it, how we want these calls to be made through skill labs. Hospital-wide, we'll create a PDSA project with a QI department. That's basically a quality project, and it's done through our intranet. So that way we're able to track and share our data with the whole organization, and we'll present the project to the Quality and Safety Board to garner more support there. In conclusion, the focus on high-risk patients I anticipate will reduce readmissions to the hospital. Since start of fiscal year in July, average monthly 30-day all-cause readmission rate was 12.73%, so there's definite room for improvement there. Re-education and refocus of discharge calls will engage staff, as current focus is on 100% patient contact, but there hasn't been a thorough discussion of the why, and there's currently no standard to prioritize the calls. Currently, there's about 6,000 discharges a month. That includes the emergency room that are eligible for the discharge call, but only about 13% get one, and there's no just structure. Expect a lot of support from other areas on this project. As an academic and magnet institution, there already exists high level of engagement and support. Also, focus on care transitions has been a priority, including improving the number of patients who get a call. Education and pilot can begin once the tool is built. We'll need to determine capability of the already existing system. We'll start as a pilot on one unit, and hopefully the results are positive. We'll disseminate the results in the program to other areas. So thank you for your time. If you have any questions, please feel free to let me know. Thank you very much.